already started the large intestine, and we do know the parts of the large intestine as far the different nomenclature is concerned. So, we call the large intestine, it looks large, right? It has a part which you have to consider is having three features which separates it from the small intestine. Having one feature we call them as Haustrations, Sacculations. Second is it's a belt like structure, three of them longitudinal bands, and third one is the pouches, fat pouches, Epiploicae, Teniae Epiploicae, which is present to it, which is separating from the small intestine. Now this particular large intestine starts from cecum, and then ascending colon, transverse colon, descending colon, sigmoid colon, rectum. So this is how this particular whole thing is described. Now small intestine, how many parts we have? 3. And the junction of these large intestine and the small intestine we call them ileocecal junctions, which is guarded by a valve. What is the function of the valve? Prevent regurgitation. So it's a one-way transport, which you have to keep in mind. If you just like land up in gastro medicine, gastrosurgery, that valve matters a lot for us to do any interventions related to that particular part. But anyway, so coming to this particular large intestine parts that we have known now, this particular large intestine is supplied by the blood supply, coming from two sources. Is coming from the branch of abdominal aorta, and the branch which is coming in here we call them as superior mesenteric artery and inferior mesenteric artery. So this superior mesenteric artery is SMA in short, which supplies this which embryological remnant we talked about? Midgut. That particular midgut forms a loop. That loop we call them as intestinal loop. So that particular intestinal loop is forming all these parts of the ileal, jejunal, diverticulum, jejunal coils, and as well as these parts of this particular large intestine, cecum, appendix, up to the transverse colon. So if you just like have this particular large intestine formed, if you have this ileum, then we have the cecum, and then we have this diverticulum coming on this back side of the cecum, then we have this which is going on this particular intestine, we call them as this large intestine, we call them as ascending colon. Ascending colon related to this particular organ which halts in this region, we call them as liver. Now this region it hits over here and makes an impression. Remember in the liver we talked about the impressions on the visceral surface of the liver. We have this particular large intestine making a bend in this particular region, we call them as impression of the colon, we call them as colic impression. We have this particular colon marking here, we call them as flexion, right. So this flexion we call them as hepatic flexion. Now this is related to which side of the body, abdomen? Right side. So we call them as right flexure, as well as we can call them as hepatic flexure, right. So this is a bend. Then what it will be doing? It will be going transversely. So it will be running transversely to this spleen. Now the position of the spleen is little high up, so it is have to climb up to reach to this particular spleen. Again in the spleen, it makes an impression there. We call them as colic impression on the spleen. Remember that under the hilum. So it is going transversely accordingly and reaching this particular point. Then again it will go on to be going down. So it will going to go down. We call them as descending colon, and then it will going to make a curve, which is going to make a curve and looks like a S. So it's making a X-shaped curve, we call them as sigmoid colon, and then it is going to make a straight curve like rectum, which is little bit dilated and then end up into here. So this particular entire organ that we are seeing here is placed in this particular thing. Now related to this particular organ that we are seeing here, that we are going to describe or going to talk about, running across this particular cecum appendix to this particular rectum, we have a diameter which we need to consider here. So the diameter, transverse diameter, is wider down here. on the right side. It is narrower as you go to the left side. So, it is narrowed on the left side and right side it is wider, right. So, this particular difference matters when you land up in pathology or pathological aspects of this particular disease of this particular large intestine. Then we are going to talk about this particular diameter, then this diameter will matter to us. Remember that particular clinical difference on transverse diameter on this ascending colon is more than that of transverse diameter of this descending colon is less, and being that have got some clinical significance to it. That is what you have to keep in mind at this point. Now, this particular segment we call them as A, this particular segment we call them as B, we call them as C and D. So, this A segment and the B segment is lodged inside this abdominal cavity, we call them as gutters. They are placed on the sideways. So, inside this particular region we call them as gutters region or flanks of this particular abdominal cavity. Now, this A and C section is retroperitoneal, that means it is placed or pasted on the posterior abdominal wall, that means it is little bit on the backward portion. Retroperitoneal means this is pushed to the wall. So, that is basically anchored to this wall. So, mobility of this A and C section is less, it hardly moves because it is hitting on the back, does not have much of space room. This section transverse colon have got a mesentery attached to it, we call them as transverse mesocolon. Now, this particular transverse mesocolon is little bit mobility having it. So, it is a little bit mobile, it is hanging down here, and above here we have this particular stomach. Remember that stomach has a greater omentum. So, this transverse mesocolon blends with this particular omentum of this region, we call them as greater omentum. So, this particular region have got mobility. So, this part is little bit mobile here, this part is fixed. Why it is fixed? Because it is pushed to the posterior abdominal wall and do not have any peritoneum. So, this particular thing which is this mesentery, it loses the mesentery. Why it loses the mesentery? We will talk embryologically, that will become significant for us to understand why this particular element is fixed on the posterior abdominal wall. So, remember this mobility of this particular ascending and descending colon is less than that of the transverse colon. Transverse colon is mobile because of having the mesentery attached to it, we call them as transverse mesocolon, right. So, this particular element that you have to keep in mind. Again, the sigmoid colon having a mesentery, we call them a sigmoid mesocolon. So, sigmoid part as well having a mobility as well. Now, this particular sigmoid mesocolon or sigmoid colon is related to an organ which is running retroperitoneally. We call them as ureter, which is bringing the urine from the left side kidney down to this urinary bladder. So, this ureter, remember that ureter is related to this particular sigmoid colon because this particular organ as it is going down is lying superficial to it. So, this sigmoid mesocolon having this mesocolon part, and this particular sigmoid colon is mobile, transverse colon is mobile, and sigmoid colon is related to this ureter which is lying retroperitoneally. So, it is the ureter is plastered on the posterior abdominal wall, it is retroperitoneal, and this one is not retroperitoneal because it is having mesentery and free attached and it is floating little bit anterior to it. So, these particular points that we have to keep in mind related to this particular mobility and the position of this particular colon, right. Cecum, then we have this ascending, transverse, descending, sigmoid and rectum which is going down. Now, coming to this particular blood supply of this particular organ itself. So, this blood supply coming from the arteries, we call them as mesenteric arteries. There are two sets of mesenteric arteries there. We call them as superior mesenteric artery, inferior mesenteric artery. So, what are the branches of superior mesenteric artery? What are the branches of inferior mesenteric artery that we are going to talk out here? So, this region is supplied by the branch of superior mesenteric artery. Now, superior mesenteric artery is going to supply which part of this intestinal loop embryologically? SMA is going to supply embryological which segment of this developing foregut tube? Gut tube? Midgut. And inferior mesenteric artery is going to supply which part of the gut? Hindgut. So, midgut and hindgut is supplied by accordingly this particular segment. Now, the superior mesenteric artery supplies this particular midgut loop. That midgut loop develops from primary intestinal loop. The primary intestinal loop that we talked about here is PIL. That means it is beyond the duodenums, or duodenum is divided into two parts, above this opening of ampulla vater and below this opening of ampulla vater, right. So, below this opening of ampulla vater, this duodenum, part of the duodenum, we call them as lower part of the duodenum, and beyond anything, the coils which you have, ileum, jejunum, the cecum, appendix, ascending colon, transverse colon, and transverse colon up to here we call them as the 2/3 and 1/3 junction. So, up to this much we develops from PIL or primary intestinal loop, that is we call them as midgut loop. Remember that. So, up to this much it has to be supplied by branches of superior mesenteric artery, and rest is hindgut derivative that will be supplied by the inferior mesenteric artery. Find the logic. So, this particular segment is supplied up to this part is having supplied by this particular segment by the branches of superior mesenteric artery, because it develops from that particular segment, and this is beyond that it develops from the hindgut derivative. So, that particular thing embryologically stands for the logic why this particular thing stops supplying in at this particular point, and anything beyond that is going to supply by something else. So, this embryological logic stands here to explain the different orientation of blood supply coming from the SMA and IMA. Clear or not? Likewise, we talked about the foregut derivative is supplied by branches of celiac trunk, CT. CT is supplied to which part? Up to the upper part of this duodenum, that means above the origin of ampulla vater. What do you mean by the ampulla vater? Where this opening of this pancreatic duct and the common bile duct comes in here, which is supplied by or wrapped around by the sphincter of Oddi, which is present on the duodenum. Which part of the duodenum? Anatomically second part of the duodenum. Which border of this particular duodenum opening has? The anti-mesenteric border. That anti-mesenteric border has a bulge here, we call them as papilla. That papilla is having one large, one less. We call them as major duodenal papilla, minor duodenal papilla. Remember that? Minor one little bit ahead, major one little bit down. So, that particular major duodenal papilla at the summit, which looks like a volcano, upper end which has a summit pierced by these two branches of or tubes of the pancreatic duct or main pancreatic duct and common bile duct. Clear? So, this particular element has to be supplied by branches of the SMA. So, this particular superior mesenteric artery which hangs like this. So, coming from the celiac trunk or it comes from the abdominal cavity, it goes like this. So, what are the branches of superior mesenteric artery that we have to remember here? The main continuation of this particular SMA, we call them as ileocolic artery. So, this ileocolic artery is the main continuation of the SMA which goes down to supply here. So, ileocolic is going to supply the colon, going to give some ileal branch and as well as going to supply the colon. So, out here we supplies here the cecal branch, anterior and posterior cecal branch. We talked about anterior posterior cecal branch. The posterior one goes to supply a branch which is known as appendicular branches, which is going to be wrapped into this particular region, we call them as mesoappendix. Remember that particular point we talked about. Now, this ileocolic branch going to supply here the small branches. Next, we have a branch which is going in here toward the right direction. We call them as right colic branch or right colic artery, RCA, right colic artery branches. Right colic artery branches give some small branches like this, and then we have a branch which goes to supply this middle portions of the colon. We call them as middle colic artery. So, this middle colic artery splits into two branches like horizontally, left side and right side, and goes to supply this particular region of this colon. Up to here we have these branches. So, we have three branches to talk here: middle colic artery, right colic artery, ileocolic arteries. and these are SMA. They are going to supply this particular region out here. Along here is going to give some branches which is going to curve on the left side. We call them as small branches like this one. This one going to the mesentery. It's going to supply the SMA we talked about, is going to supply this wrist part of the small intestine. That means it's going to supply this particular lower half of the duodenum, all the coils of the jejunum, all the coils of this ileum. So that means these are the branches, we call them as mesenteric branches. So they are numerous. These mesenteric branches go within the mesentery and then supply all the coils of the small intestine. So these are the branches we classify here. So branches which is known as X and Y. Y is 3. Middle colic artery, right colic artery and ileocolic artery. These are the 3 branches and sub branches which are going to supply the large colon. Small branches we call them as mesenteric branches. Mesenteric branches go within the mesentery, supplies whatever the content lying in the mesentery. So the mesentery holds this particular second part of the duodenum, holds this particular duodenum, jejunum and ileal coils. Clear? So this is how this particular entire things are going on. Now then we are left with the inferior mesenteric artery. So this inferior mesenteric artery comes down like this and it goes to supply this particular region like this. So it's go to supply these particular branches. It goes to the left side towards the spleen side. Just like we have the right colic branch, we have the left colic branch. So this left colic artery which goes to supply left side of the colon. Now this particular left colic branches, one climbs up, one goes down. So ascending branch and descending branch. The ascending branch goes to supply this particular upper half of this particular descending colon. Descending branch goes to supply the lower part of this particular branch which is going to lower half of the descending colon. And they meet with these particular branches of this particular middle colic artery as well. Now what this particular other branches do? They go to supply this particular sigmoid colon. We call them as sigmoidal branches. And main artery continues down as is superior rectal artery. They supply the upper half of the rectum. Clear? Now, so this is how the whole thing is supplied and network like this. Now, whatever the thing is that we have to remember here, these particular branches or sub branches like ileocolic, right colic, middle colic, left colic, they gives into smaller branches. They give the smaller branches and we comprehend the smaller branches, not the smallest one, but the smaller branches we call them as marginal branches. So marginal branch is kind of universal branch. That means small branch from any of these particular colic arteries we call them as marginal branches. So these marginal branches join with each other, make some network. We call them as anastomosis. So anastomosis can be of different types. Now they may have anastomosis vertical, we call them as vertical anastomosis. Anastomosis may be on the sides, we call them as sideo anastomosis, depending on how this anastomosis is there, right? If you are joining hands with above, down, sideways, we call them as accordingly. So there are 4 different types of anastomosis that can happen. But we are not going to talk about those kind of anastomosis. But here we are going to talk about the anastomosis which is taking place between these particular marginal branches. So this word is important. Marginal branches, and there is anastomosis which is existing between them, we call them as marginal anastomosis. So these particular branches we call them as marginal branch. What do you mean by marginal branch? Any branch which is coming from these particular sub branches, that means branches of this ileocolic, middle colic, right colic, they give branches. So those branches we call them as marginal branches. What do they do? Marginal branches, they split again, but before splitting they have an anastomosis, then they split. So this particular marginal branches anastomosis which is existing close to the organ, we call them as marginal anastomosis. So it's been observed by somebody and he named it Drummond anastomosis. But anyway, so this marginal branches anastomosis matters to us. So this marginal anastomosis exists between this particular colon, like cecum, ascending colon, transverse colon, descending colon, everywhere, and as well as sigmoid colon everywhere. So this marginal anastomosis, significance of this marginal anastomosis that we have to know. So if you have an anastomosis, what benefit we can acquire out of having a anastomosis like this? If you have an anastomotic network, is there any beneficial to it or not? If yes, explain why. एक जगह block होले उन्नो जगह artery supply करते हैं. What does it mean? What does it mean? Can anybody elaborate it? Okay, I am not going to explain, right? You are going to explain. Find it out. What is the clinical significance of marginal anastomosis? Clinical significance of marginal anastomosis. 3-mark question. Find it out. Now, points where we have weak anastomosis of marginal branches. So these are the points where you have a chances of ischemia. So which can happen naturally with some ages, etc., etc. So these are the points where you have ischemic damage. If what happens if you have ischemic damage at this particular point, then this marginal anastomosis plays a role to come back or overcome this ischemia having through these particular anastomotic networks. So this is what you have to understand, learn about this particular marginal branch, marginal arteries and marginal anastomosis and significance of having marginal anastomosis. Now coming quickly to have this particular organ, how we are going to, now do not close it, you keep on writing again and again till you find a proper answer. Marginal branches, marginal arteries, define marginal arteries, then marginal anastomosis, then blockage of this particular clinical thing which we have talked, and what are the points which are vulnerable for anastomotic ischemias. Now this particular organ, while you are writing, you just like have a look, it is not a like a big rocket science about it. So how to hold this particular large intestine in anatomical position. Now it is soaked within fluid, so that I am just like letting this particular fluid flow. Now you have to identify which side is right side and which side is left side. How to identify right and left? Cecum to left side, right side. Sure, sure. How much sure you are? Only 100. Okay. So where is the cecum? This side. This side. Cecum. Cecum is identified by presence of appendix. If the appendix is not there, is already appendicectomy is done there? Ileocecal junction. So terminal part of the ileum you will be looking for. Then we can find this. So this side is right side, this is left side, and in between transverse colon. So this is on the right side, this is on the left side. Now this particular bend we call them as right bend, hepatic flexure. This one, which one is in a higher position? Splenic, right? So this is the way you are going to have this. Both hands used, right on the right side, left on left side. If the examiner wants you to focus on the cecum appendix, then hold the cecum appendix individually. How to hold this in anatomical position? Right and left identified by, कैसे पता चलेगा कौन सा साइड राइट है लेफ्ट है? आप कहाँ में थे? क्लास में थे या अभी तो बताया, क्लास में थे या कहीं और जगह में थे? हाँ, कहाँ में रहते हैं आप? So which side is right side? कैसे पता चलेगा? Cecum कौन सा है? Is a part of large intestine or part of small intestine? Large है. कैसे पता चलेगा large intestine है? What are the features of large intestine? What are the cardinal features of large intestine? बताइए. कैसे पता चलेगा?
parts of large intestine, parts of small intestine, how to identify the features of large intestine. Before you leave, write it down and check with me. Right, parts of large intestine, parts of small intestine, cardinal features of large intestine, everybody. How to distinguish between the large intestine and the small intestine. লেখো, ওটা লিখে আমাকে দাও, তেমন হলে 10 বার করে লেখো, 10 times you write. বললাম তো শুনলি না? Yes, write about the blood supply of this small intestine and large intestine. So answer them. Before that, you are not leaving.